So for this session, we'll now take a look a little bit more closely at the components of what we call the important mental status examination. Remember that the mental status exam is always what we call labile. No? It's changeable, no? Depending on the situation of the patient. So it can change every hour or every minute. So you might, in your clinical exposure, for example, in the psychiatric ward or in the ICU, when you're caring for patients with mental disorders, you might find that the mental status exam changes moment by moment. So here you will learn about the importance of the mental status examination and its various components. So as I mentioned earlier, it's important to take note that the mental status exam is transitory, it's changing. In fact, it can change very quickly, even in an outpatient setting. So your patient may look different a week before, and then the next week or the next month, he or she will might present differently to the clinician. So it's important to include all of these details, no, in all of your clinical encounters. The mental status examination in psychiatry is very important, as I mentioned earlier, because uh, it is more or less equivalent to the physical exam in internal medicine. It is the tool for diagnosing our patient. In every single encounter with a patient, in every mental status examination that you do, you must always evaluate, assess for the safety, including suicidal or homicidal thoughts of the patients. No, if what are their intentions? Do they have actual plans to carry it out? And what is the history of the patient with regards to safety issues, including suicides and homicidal thoughts? And so we must explore whether there is any intent or plan to carry it out. So remember, the mental status exam needs to be recorded at every single encounter with your patient. So there's a lot of elements that you will see during the mental status exam, and we will go into the details of which later. So we will start with appearance and behavior. So we're starting with appearance and behavior. So when you see a patient, you start with the appearance and the behavior. So it's just like when you see somebody on the street or in a meeting, or you've encountered someone, you notice something about them. And when you look at them, you take note of what are the important elements or information that you can get from them, especially when you notice their physical appearance. So what's their clothing, uh, their hygiene, what's their posture, and what's their grooming. So how they are dressed, how do they look like, what's their posture, are important descriptors, no, of the physical appearance. Also, you have behavior. What are their mannerisms? What are their tics, itong mga involuntary movements? Did they make eye contact with you? So you may notice what we might term as presence of psychomotor agitation. Like, are they moving too much? Like, they're restless, or maybe they seem very slowed down, or they're barely moving at all. So just like catatonic, what we call your psychomotor retardation. So, so aside from the physical appearance and the behavior, you also want to take a look at their attitude. No? Are they cooperative? Are they hostile? Are they guarded, seductive, apathetic, etc.? So you want to take note of this information. So are they engaged or excited, or are they apathetic, or they look like they don't want to be there with you? So you have to take note of these elements. So make sure also that you have to take note in your comments that there's enough details so that anyone else who reads your report, no, who reads your uh, mental status exam, whether it's a colleague or another doctor or your supervisor, they will be able to make, uh, they will be able to understand, no, get a picture of your patient without actually seeing them based on your description of them. Next, let's consider speech. So when talk about speech, what are the elements that you look at when you are involved in trying to describe somebody's speech style? So you have rate, you have volume, you have articulation, and you have your tone. So let's start with the rate. The rate can be slow, average, rapid, pressured. So pressured is continuous, fast, and uninterruptible speech. So that's what we mean when we say that the speech is pressured. Volume can be described as soft, average, or loud. And articulation can be described as well articulated, lisp, or a stutter, or they might be mumbling. Or also you could describe the tone. Are they angry? Are they pleading? Do they sound happy, content? So these are all important clues to what could be the kind of mental health problems or a kind of psychopathology that is going on, no, with the patient. Let's now go to mood and affect. So a patient's mood is actually the emotion that tells you that they're experiencing. So what are they experiencing is the mood, no? So the emotion that the patient tells you that they're experiencing is their mood. So they can convey this to you either verbally or non-verbally as well. So on the other hand, the affect is really the assessment of how the mood appears to be coming out on the exam. And you want to know the kind of range and emotional expression that you see your patient is having. So here's a little question. What would you call the depth and range of feelings that are shown? The parameters could include a flat or lack of affect, a blunted or shallow affect, constricted, limited, full, average, or intense. So these are all described as quality. So depth, range of feelings. On the other hand, what describes how quickly a person's mood appears to shift? So shifting emotional states, meaning the parameters including sluggishness or supple or being labile. That describes the motility of the patient's mood. So the parameters here are whether or not the patients appear appropriate or inappropriate, given the context and the content of what you're talking about with, with the patient. So the appropriateness of the content will describe whether the affect, what the patient is showing, is congruent with the subject of the conversation. So the way to describe this are through the parameters of either they are appropriate or not appropriate to the content. that you have. Now let's take a look at the thought processes of the patient. So here, the thought process actually describes how he or she uses language and put ideas together, as this is what you call your form of thinking. And understanding the patient's thought processes is important. It is important for us to use our listening skills. Now, it's extremely important to be able to know how to listen to what the patient is saying. Nobody's going to tell you how they're thinking. So you have to discern this. You have to discern this on your own based on your conversation with them. So the thought process describes how your patient uses language and puts ideas together. Okay? So it describes whether the patient's thoughts are logical, meaningful, or whether or not they actually goal directed. So the thought process does not actually comment on what the patient thinks. No, it's not a comment on what the patient thinks. It only describes how the patient expresses his or her thoughts. So this is really important in considering the different types of psychopathology, such as manic or psychotic thought processes. So when you talk about manic or psychotic thought processes, there are certain disorders that affect, no, the thought process. So just as I mentioned earlier, you could have mania and you could have psychosis, and the thought processes are affected. So when you're describing somebody's thought process, there's a lot of different ways in which you can describe it. Okay. So here are some disorders, no, that could affect the thought process, and how you can describe, no, the different thought processes that are affected, no. So these are the thought processes that are manifestations of some problems or mental health problems that the patient has. So this list are a few different ways to describe someone's thought process. So if you find somebody who is not able to make logical connections, no logical connections from one thought to another, what would you call that thought process? You would call that as the loosening of associations. What about when somebody has a very fast stream of very tangential thoughts? We call that flight of ideas. Sometimes patients will make up words, no? And when you find that happening, again, requiring you very attentive listening skills on our part as clinicians. So when you find somebody making up words, no, you would describe that in your mental status exam as neologisms. All right. And when words or connections due to phonetics rather than the actual meaning are present, that you would be your clang associations. So example of what would be a patient rhyming words together where it doesn't make sense, or maybe using alliteration and starting of every word with, let's say, sound, but they're string together without making any sense, but they are just, they are connected by similarities in sounds. It's called clanging. And it's what we call an abrupt cessation of communication before ideas are finished. We call that thought blocking. So hindi natatapos yung kanyang sentences, no? Kanyang thoughts. Thought blocking is very important to note, no? And thought blocking is a key signal that there's some sort of a psychotic process that is happening to the patient. So when you see a patient where there's a point of conversation, but it never reach uh, the it never arrive at a closure due to a lack of goal-directed association between ideas, then that's what you call your tangentiality. Okay, tangentiality. If you have a point of conversation However, that point of conversation finally reaches what they want to convey, but it goes around a circuitous path. We call that circumstantiality. So the difference between the two is that this tangentiality, you never arrive at the point of the conversation, no? While circumstantiality, you arrive at the point of conversation, but after only a very circuitous route. So the thought content is an important piece to the mental status examination as well. There are different things to keep in mind, different types of ideas that are expressed by the patient. So, for example, when a patient uh, says too few versus too many expressed ideas, this is what we call poverty of thought versus overabundance. Okay, so if they have too few, then that's poverty of thought. Too many, then that's overabundance of ideas, of thought. So to explain that again, poverty of thought versus overabundance is when a patient either says too little or too much. Okay, so that's the difference in terms of the volume of thought content. On the other hand, when you have fixed false beliefs that are not shared, no, by the person's culture and cannot be changed by reasoning. So, for example, if the person believes that the world is flat, so it's not shared by the person's culture because we all know that the world is not flat; it is uh, spherical. But the person is under that belief that is fixed, but it is false because it's not shared by the person's culture. Then you call that delusion, because you can that is delusion if it cannot be changed by reasoning, no matter how much you explain that to the person. If you ask the patient if they feel like harming themselves or others, we are of course screening them for suicidal and homicidal thoughts. So you have to make sure that I have to ask the patient, no, if after asking them if they have any suicidal or homicidal thoughts, do they have the intention, no, to carry the harm to themselves or to others. So you have to ask whether or not they have a plan to carry it out, and that would feed into your risk assessment for suicidal and homicidal ideation. There are also some ideas that can be expressed by the patient that are persistent and irrational fears. Now, those are known as phobias. So phobias are also important uh, types of ideas expressed by the patient. So they are persistent and irrational fears. So, for example, fears of open spaces or fears of closed spaces uh, that are irrational, then that's a phobia. Or fear of snakes, or fear of bicycles, etc. Fear of heights. So, what is it when patient or somebody has what we call repetitive or intrusive thoughts? You call that obsessions. No? So, when what is it when a patient displays repetitive behaviors that they feel that they're out of their control, and maybe like something like turning on and off like switches or counting things or washing their hands repeatedly? That's what you call compulsions as well. Another element of the mental status exam is perception. So perceptions are key component of the mental status exam. While perceptual abnormality is known as hallucination. What is hallucination? This is a sensory experience not based in reality. It can be visual, auditory, tactile, or by touch, gustatory, a taste, or olfactory smell. So that's a perceptual abnormality called hallucination because it is not based on reality. So they are seeing things, hearing things, or experiencing things that are not present. Another perceptual abnormality is called illusion. This is an inaccurate perception of existing sensory stimuli, and it's important to note that the type of the type of stimuli is important. So the type of hallucination is important because you always want to dig deeper with the patient. So what kind of visual, whether it's visual, auditory, or tactile, or gustatory, olfactory, will indicate what kind of psychopathology they might be having. So for instance, in the clinics, if you're encountering an individual who tells you, "Doctor, I am hearing things, I hear voices," I'm going to take it a little further than, and I'm going to ask them, "Well, who's talking to you? Do you recognize the voice? Is it one or more? Can you describe the voice that you're hearing and what exactly are the voices saying?" Because you want to differentiate if the patient is experiencing what we call a command hallucination or a command auditory hallucination versus a running commentary hallucination versus something that's persecutory. So when you want to ask questions about this, you can probe a little bit further, especially when somebody is hearing voice. Always ask them if the voice is telling them to hurt themselves or to hurt someone else, because that is an important element of your mental status exam. Okay, cognition is another important uh, element of the mental status exam. So when you talk about cognition, there are certain things that you're going to ask about in every encounter of the patient. So consciousness is one of those. No? So how would you go about assessing a patient's consciousness? Well, you're going to ask them about their level of awareness, and this possible range of awareness will include whether they're alert, they're drowsy, they're lethargic, they're stuporous, or they're comatose. You could ask them the orientation with regards to person, place, or time. Do they understand the situation where they are in? You can ask them for calculation. So this is a very good test, no? Addition and subtraction is a very good test for what is called your executive functioning. So do you have any ideas about how would you go about assessing executive function? Well, numbers are a good way to assess executive function. So you can ask the patient to subtract. You might ask them to do serial sevens by counting backward. So you want also to assess the memory. So you can also assess the memory. And how would you assess memory? So you can assess for immediate memory by asking them to repeat several digits or recall 3 words after 5 minutes. So the 3 word test is a really good rule of thumb, no, to test for immediate memory. So if you want to assess for recent memory, you could ask them for the events within the past few days. For the recent past, you could ask them about events within the past few months. How about remote memory? You could ask them for their stories, no? Events from childhood. How about the fund of knowledge? You could look at the level of knowledge in the context of the patient's culture and education. So you could ask them about presidents, or the national bird, etc., etc. For testing attention and concentration, you could ask them to subtract zero sevens or spell backwards. So that's a test of attention and concentration. Of course, for reading and writing, you could ask them to read simple sentences. Abstract concept, the ability to do abstract conceptualization. You could ask them to explain similarities between objects and understand the meaning of simple proverbs. So they could use that example to be able to arrive at similarities. Then you're testing for abstract concepts. So you have your mini mental status exam, which you can use to briefly test for a gross cognitive function of the patient. So for example, for abstract concept, you can ask them for the difference between an apple and orange and what's their similarity, for instance. So they could say they're both circular, which would be very concrete thinking, and that would be a good test for their abstract concept. So all of these are important components of the mental status exam, including what we call the ability to, to have insight or to engage in judgment. Insight is the patient's level of awareness and understanding of his or her own problem. So insight into his own or her own problem. So problems within insight might include complete denial of the illness or blaming it on something else. While judgment is the patient's ability to understand the outcome of his or her own actions and use this awareness in decision making. So these are important elements of your mental status examination. So they can affect understanding of the problem and therefore affect adherence to treatment. For instance, if they are in denial, they don't understand that they have addiction problem, then the treatment management will be much more difficult. We're now going to talk a little bit about suicide risk assessment. It is something that is critical to psychiatry, especially in the context of the pandemic, where there's an increasing number of mental health problems, especially among the young people. And there's anecdotal evidence that there's an increased number of suicides, especially among the young. So it's important to pay attention to this part of the psychiatric assessment, assessing for suicide risk. So suicide is defined as the intentional taking of one's own life. No? So it is not an accident, it is intentional taking of one's life. So that's suicide. And there are so there can be several risk factors that can play into suicide risk assessment. So this can be passive suicidal ideation. So you have passive suicidal ideation. This is, for example, in clinical practice, you might meet a patient who says, "Oh, doctor, my life is not, well right now, and I wish I should not wake up. I would not want to wake up in the morning." So they don't have any active plan or intent to hurt themselves. So it's very passive wish to die. So actual suicidal ideation is very different. This is where you have a patient saying to the doctor, "I'm not happy with my own life. I want to end my life now, and I have a gun or I have something that I could use to hurt myself." That would be active suicidal ideation. So the patient actually has an intent and a plan to do something here. So sometimes you will encounter a patient who has a plan, but sometimes they don't have the intent. They'll come to you to say, "Doctor, I'm not happy with my life. I think of shooting myself. However, I actually like to feel better. Can you help me? I don't want to carry out the plan." So it's very important to understand the patient's thoughts, intent, and plan. There's also what we call parasuicidal behavior, and this is where there's self-injury. But the self-injury is not intended to cause death. It's just intended to harm oneself. And we see this a lot among teenagers. In fact, personally, I have seen this among the friends of mine, among the daughter, no, or children of my friends. They do not have an intent to commit suicide, but they commit injury to themselves. So this could be often be seen in clinics as a patient who will cut themselves, burn themselves, maybe bang their head. And again, their intent is not actually to die, it's to inflict self-harm. And the problem is sometimes these patients will go on to actually accidentally cause their own death. So very important to always screen for self-injury behavior. So when we talk about suicide and self-harm and what are the risk factors for this, there is what we call static risk factors. Static risk factors meaning things that do not change or cannot be changed by the patients. There are also what we call modifiable risk factors, meaning to say these factors can actually be changed. So the doctor can actually step in and help the patient make some positive intervention in their life where they can actually change things. There are also what we call protective factors. Protective factors are important to note in your risk assessment of the patient because they build up the protective factors to help your patient best. So we will try to take a look at this in a little more detail uh, in the next slides. So in terms of risk factors, there's what we call a bimodal peak, for suicide. So it is high for 15 to 24 years old, and then it goes down, and then it becomes high again for the elderly over 60 years old. So in terms of race also, it's also uh, a risk factor. Sex, women are 3 times more likely to attempt suicide, and men are 3 times more likely to complete suicide. History of suicide attempts is also risk factors. No? So history uh, you know of suicide attempts, in the past can actually point to high risk for suicide attempts in the future. So if your patient does have a history of suicide attempts, you want to ask for more questions such as what was the attempt, noting whether it was violent or non-violent, and you want to know uh, whether it led to their hospitalization or not, whether the patient reached out for help or not, did they write a suicide note, etc. So always consider family history also of suicide attempts. So it's also important to note if the patient has a history of physical or sexual abuse. So because all of this have what we call impact in terms of risk factors. But these are what we call static risk factors because this cannot be changed. No? We have what we call modifiable risk factors on the other hand because we can actually modify these things so that we can help our patients. So for mental illness like depression, anxiety, and hopelessness, which are really key features for a lot of patients who are feeling suicidal, this can actually be modified by actually treating the mental condition. So if we treat the depression, if we treat the anxiety, if we treat the hopelessness, then we can prevent the suicide of the patients. So general medical conditions like chronic pain or end-stage conditions, if we help the patients access medical care or primary care, providers can address medical issues, they can also be modified. Professional supports like access to psychiatric care and therapy, they can also be modified because you can actually refer them to resources within the community like community psychiatry or therapy or resources within the community. Also, presence of substance abuse can be modified because we can educate them about the dangers of substance use like alcohol or tobacco smoking or illicit drugs and the likelihood of these drugs to cause disinhibition that could actually lead to suicide risks. So we can make sure, no, that we can provide support for these patients when they have what we call modifiable risks. So we have to make sure that the patients have the help that they need, uh, and that when they are faced with problems like substance abuse, then we can intervene uh, and educate them about the dangers of substance abuse and encourage them to seek out some programs like rehab programs to help them overcome substance abuse. I personally know a lot of people who have been helped by going through rehab programs, facility-based rehabilitation programs, or community-based rehabilitation programs. We have also here, I think, in the province, in the region, we have several rehabilitation programs for persons who have been involved in illicit drug use. And some of our graduates are actually working in some of these facilities. No, so ask them about access to guns, because you can actually educate about removing firearms, or removing all of these dangerous weapons from the house so that they don't have access to this. You could ask them about employment and community support, because if they don't have employment, you can refer them to training programs or programs that have support for the disabled, or that those are have available housing for those people who are vulnerable. Also, if they have what we call anniversary of a loss, for example, people have traumatic experiences that led to their conditions, then you could explore the patient's feelings, anniversaries, and allow them to have something to look forward to them, and allow them to have hope, uh, support them. So it's modifiable, no? This risk factor of, like for example, people have experienced disasters like Yolanda, or the tragic loss of someone. You can help them by making sure they have actually have an outlet to talk about their grief, and they can look forward to meeting with someone who might understand, whether it's one-on-one or a peer support group. So protective factors are also important for patients, no? So remember, these are resilience factors or protective factors against suicide. And these are the list. You have supports, financial stability, employment, marriage, relationship, children, even having high intelligence, a high level of education, or stable housing, or a history of resilience. All of this allows people to be protected, no, from a risk of suicide. So, for instance, in our own study and research, we have found out that when people have what we call stable relationships, or they belong to a strong community, for example, they belong to a church group or a religious group, they tend to do better in terms of their outcomes, no? Mm, in terms of their health. So having a support community can really help save lives, no? So all of these are important protective factors. So when we do our mental status exam, we can also do a suicide risk assessment. And some key things to keep in mind are that the mental status exam in psychiatry is really like akin to similar to the physical exam in internal medicine. It's an important uh, element, no, of your assessment of the patient. So it's important to focus on that and pay attention. Also, for example, to suicide risks that needs to be done at every patient encounter, especially for psychiatric patients. So you can actually modify those factors that are modifiable and promote protective risks, protective factors, no, that decreases the risks, improves patients' safety as well. So I think that covers our topic on that session. Thank you.